Hi, my name is Klara Rosenquist. I'm an endocrinologist and one of the obesity medicine physicians at the Weight Center. Today, I'm going to be talking to you about healthy weight at midlife and treatment options. I have no disclosures. So these are the objectives for our 20-minute discussion today. So first, we're going to define the risk of midlife weight gain, determine the risks, and understand how to address them in the setting of obesity treatment. We'll really focus most of our discussion on the treatment and understanding the use of anti-obesity medications. And then we'll end with the discussion around the care plan and treating obesity really as a chronic disease in order to optimize outcomes. So first, let's just start with defining the risks of midlife weight gain. So weight gain and obesity is common among aging women, especially during this menopausal transition. Postmenopausal women have changes in body fat distribution, specifically around increased central and adipose tissue, visceral adipose tissue. Women with obesity in midlife are more likely to report frequent and/or severe hot flashes and symptoms of sexual dysfunction. Most evidence suggests that the weight gain in midlife is primarily a combination of results of aging, changes in body composition, and lifestyle changes. And that menopause per se does not significantly result in significant weight gain after adjusting for these other contributing factors. Certainly, this is a little bit of a gray area and still an area of discussion, but it certainly seems that many of the risk factors are related to other changes that are taking place at this time. So let's understand the pillars of obesity treatment and apply them to obesity treatment. So when we meet patients at the Weight Center, we really focus, especially at our initial visit, around history of modifiable risk factors. What's their nutrition like? What's their daily physical activity and exercise? We talk about concomitant medications, the risk of weight gain with some medications, the history of stress, ongoing stress, and certainly around sleep as well. So we really focus our discussion on this. Certainly we talk about genetics. That is certainly a trigger and a risk factor for weight gain. But since that's not modifiable, we really try to focus our discussion on what is modifiable. Again, specifically for women in midlife, weight gain has this unique and interrelated risk factors during the time of menopause. There's a component of estrogen deprivation, mood disorders, and medications used to treat symptoms, specifically antidepressants, have been shown to promote weight gain. Sleep disturbances, we know that sleep is so important in metabolic function and weight management, and the disturbance of sleep that comes with midlife and menopause certainly can be disruptive. And then this idea of body composition changes, decreased lean muscle mass, and typically a resulting decreased resting metabolic rate. And typically for most women, also decreased physical activity around this time. So here's an obesity treatment pyramid that I like to refer to often. So along the left-hand side here, you'll see increasing health risks and BMI, and the increase of treatment intensity with that. And then on the right-hand side here, you'll see the typical or average total body weight loss percentage with each of these interventions. So along the bottom, you'll see lifestyle modification. Absolutely something that we talk to all of our patients about. Again, going back to those modifiable risk factors, what is it that they can change in their lifestyle? We also typically talk to patients about prescriptive nutritional interventions. We have a great team of dietitians, often have them meet with the dietitians to talk about changes, dietary changes as well. And what we'll focus most of our discussion on today is pharmacotherapy. So here in the middle of the pyramid, we have pharmacotherapy. Pharmacotherapy is indicated for patients with a BMI greater than 27 with at least one obesity-related comorbidity or a BMI of 30. And then as we continue to go up the pyramid, you'll see here we've also included endoscopic tools and other invasive procedures as well as surgery. Surgery is indicated when patients have a BMI greater than 35 and one obesity-related comorbidity or a BMI greater than 40. Again, our topic of discussion today is really going to be around pharmacotherapy. But I just want to highlight here again along the right-hand side that what we see is in pharmacotherapy, Certainly previously, we would see typically about a 5 to 10% weight loss, even with pharmacotherapy. But now we're starting to see more of a 10 to 20% weight loss. And so this is really a new time in the use of pharmacotherapy for weight management. Again, we're starting to see pharmacotherapy that's starting to approach some of these endoscopic and surgical procedures. So here on this slide, I want to highlight this slide. This is actually a slide that I sometimes show patients as well. And this here is what some people call the tug of war of weight management, what some people call the weight set point or metabolic adaptation. But here's this concept that on the left-hand side of this slide, you'll see that with a calorie deficit and an increase in activity, patients will often lose weight. However, there is something that we consider the weight set point, which is that your body will do what it can to defend the weight that it's at. And so if there's a loss of weight, your body will have this metabolic adaptation or compensatory mechanisms that kick in order to regain that weight. These are changes around metabolism, so slowing metabolism. These are increasing hunger hormones. A hormone called ghrelin is increased in this setting, as well as decreasing fullness hormones. And so a hormone called GLP-1 is typically decreased in this setting. So this is what makes consistent long-term weight loss and the sustainability of that weight maintenance very challenging in the long term. And that's where anti-obesity medications come in. So let's focus most of the rest of our discussion now on the use of anti-obesity medications for weight control. So first, let's talk about why we use them or when we use them. So the initial question we ask is, does the weight loss goal suggest the need for medications? For example, if you have a patient that has a desired weight loss of maybe 5 to 10 pounds, chances are you wouldn't want to consider medications at that point, but focus on some of the other lifestyle interventions. When do we add these medications then? Certainly, if they meet the BMI criteria, it's something to consider. Again, that BMI greater than 27 with obesity-related comorbidities or greater than 30. If our weight loss goal supports treatment, so again, depending on kind of the amount of weight loss we're hoping for or expecting, would support the need of treatment. Certainly the continued use for weight maintenance. So again, going back to that weight set point, to that need for long-term care in order to help maintain weight maintenance. And then also considering other comorbidities. Patients sometimes will come in with another comorbidity that they're really hoping to address to decrease the risk of, and weight maintenance or weight loss is an important part of that. We also consider what we are treating. So is this a behavioral component? Is there a component of stress, emotional, potentially binge eating that we're trying to address here? Is it an appetite component? Do people feel like they have constant hunger, very large portions without being satiated or satisfied? Is this an energy just expenditure consideration where the resting metabolic rate is very low for these patients? Or is there a metabolic disease here that we're considering? Is there prediabetes, insulin resistance, hyperlipidemia, hypertension that we're considering as well? So then how do we choose an anti-obesity medication? Unfortunately, realistically, insurance is one of the first things we consider, which is just an unfortunate reality of where we are right now. But Medicare does not cover any of the anti-obesity medications. So typically, if a patient is on Medicare, the discussion becomes what generic medications can we use that might be helpful? What is this patient's potential for higher out-of-pocket costs or considerations around that? Medicaid coverage is really state dependent. And so it depends on where you practice as to what the availability might be on the Medicaid for patients on Medicaid. And then certainly the medications that we're going to talk about shortly all really have variable coverage depending on the insurance and even on the policy. Another consideration is contraindications or risks. So certainly with GLP-1, we always screen for a history of pancreatitis, as well as any family history of medullary thyroid cancer. So if you're considering a GLP-1, something very important to think about. With topiramate, we think about kidney stones. Phentermine, you certainly wouldn't consider in anyone with a cardiovascular history or severe anxiety. Bupropion, we wouldn't want to use in anyone with a history of seizure disorder, And naltrexone, we certainly wouldn't want to use in someone who has active opioid use and chronic pain management. Are there opportunities for double benefits? So in patients where there's migraines, is topiramate potentially an option? In patients with a history of depression or maybe untreated ADHD, is bupropion a consideration? So certainly, is there another benefit we could consider? And along that same path, certainly if a patient has diabetes, prediabetes, insulin resistance, we certainly frequently consider metformin and SGLT2 if they have diabetes, and certainly a GLP-1. Again, we'll talk about it shortly, but the GLP-1s had first come out as restricted to patients with diabetes. But now that we have several agents that are FDA indicated for weight loss, we have more opportunity to use these even in patients who have diabetes. So let's start with some of the older agents, and then we'll focus the rest of our discussion on the newer agents. So phentermine is one of the oldest agents we use. It's a stimulant. It can increase blood pressure, and we wouldn't want to use it in anyone with cardiovascular disease or uncontrolled hypertension. Side effects are stimulating palpitations and tachycardia, increased blood pressure. Certainly, it can affect sleep as well, so patients always take it first thing in the morning. Just some practical tips around phentermine. The FDA has only approved it for a few weeks. Most people interpret that about 3 months or 12 weeks. However, there are quite a few studies that show the safety and efficacy of long-term use of this medications. So specifically, in a study that looked at it up to 24 months, there was significantly more weight loss in patients who were on it for that period of time versus shorter-term patients. And from a safety perspective, there was no cardiovascular death. So that certainly is reassuring for all of us. Systolic blood pressure even lowered over the long run, most likely related to the weight loss associated with it. So from this perspective, at our site, we do feel comfortable using phentermine beyond the 12 weeks, but this can be restricted again a little bit more state to state as well. There is a combination form, including both phentermine and topiramate. This is branded under the name Qsymia. So you have the stimulating properties of the phentermine, and then you add on the topiramate component. This adds risk factors around kidney stones, so certainly something to think about. And from a side effect profile, I'd say most patients that are on topiramate have, if they have side effects, it's typically around the cognitive impairment or other concerns that will limit sometimes the use of these medications. This is approved. So the Qsymia has FDA approval for long-term management. Again, going back to the phentermine discussion, we kind of use this FDA approval to kind of go back to phentermine and feel that it is safe for the use in the long run. Not a consideration, certainly in the population we're talking about with this medication, but topiramate should not be used during pregnancy, and specifically none of the weight loss medications should be used during pregnancy as well. Orlistat is another old medication. Its use is really limited typically by side effect profile. It's actually really an effective medication, but for most patients, the side effects, which are the greasy, oily stools, are the rate limiting factor for this medication. It blocks fat absorption, so it comes out in a stool, and this can be a challenge with this medication. There's also a risk of oxalate hyperabsorption, and if patients need to be considered or monitored for the fat-soluble vitamins, and likely need to take a multivitamin for this medication. Another branded medication is naltrexone bupropion. This is branded under the name Contrave. This is a really helpful medication when people have a component of binge or emotional eating. Can be really helpful from that perspective, and really help if someone's coming in with some of those behavioral components that we talked about earlier. Now let's get into the GLP-1s. So the first one to come on the market was liraglutide, initially branded or FDA approved only for diabetes, but then Saxenda came out in its daily use. It is a GLP-1 receptor agonist. It increases fullness and decreases gastric emptying. The most common side effects are GI-related: heartburn, nausea, indigestion, and more long-term constipation. Again, there's that risk for medullary thyroid cancer and pancreatitis, and so those are good things to consider as well. Typically, the side effects are the GI-related side effects, and that is what most often will cause discontinuation of these medications if stopped. getting my head of myself here. So the next one to come out was the semaglutide. Again, GLP-1 receptor agonist. This one is a once-a-week injection, initially approved for diabetes under the name Ozempic, and then approved for weight loss specifically under the name Wegovy. This medication came out summer of 21, and we're seeing a lot of enthusiasm around this medication. You'll see here, prior to this medication, we were seeing about a 5 to 10% weight loss with these medications. This was the first one where we were seeing upwards of almost 18% after 68 weeks. So really kind of a game changer, as everyone was saying at that time, and continues to be certainly. So very exciting new area of treatment of obesity. There's another study showing again at that 68-week mark a significant improvement, almost 18% total body weight loss, which is really significant. I do want to show that any of these studies are done really in the long term. This one used a 68-week study design. So when we think of these medications, we really think of their effect really in the long run over many months, if not several years. Now, here's the latest one to come to the market, tirzepatide. Initially came to the market, again, only for diabetes under the brand name Mounjaro, and now more recently, just FDA approved as of November for weight loss specifically under the name Zepbound. This is both a GLP-1 receptor agonist, and I'm sorry, I should have added, as well as a GIP. So this is a dual agonist here. Again, that same side effect profile as the other ones. Again, when this study came out, others talked about this is even more revolutionary. So now we're looking at a 72-week study design. At the highest dose of 15 milligrams, there was a 22.5% total body weight loss. So these are just really big numbers that haven't been seen before. And there's a lot of excitement within this field about the level of weight loss. We're seeing really starting to approach some of the weight loss we hadn't otherwise seen with weight loss medications, and we were only seeing with surgical procedures. So let's finish in just the last couple minutes about talking about our care plan. So with any patient we see at our clinic, we start by diagnosing their risk or their obesity level to try to help understand where we are really maybe in that pyramid, or really where we are in our goals for this patient. We consider a nutritional plan. We have a great dietitian team that we lean on, but certainly this is something that you can do individually with your patients as well. We talk about exercise and activity, trying to set a goal for at least 150 minutes a week, or if not starting there, certainly setting that as the ultimate target. Typically ask patients to set a goal for themselves, something they feel like is sustainable, achievable for them. And then if appropriate, again, going back to those BMI criteria, if appropriate, we consider medications. And then also, if appropriate, we consider ultimately surgery down the line if that's something that the patient is interested in, and certainly if they qualify for it. And then lastly, I just want to highlight this. We follow up in a 1 to 3 month period. We really think of the treatment of obesity as a chronic care disease, a chronic illness, and the need for chronic care management in much the same way you would treat other chronic illnesses. So the ongoing treatment over the long run, ongoing management, ongoing accountability help with the ongoing treatment of this over the long term. And lastly, I just want to end with this idea of really changing the paradigm. So really trying to focus on patient-centered care, addressing the full person, modifying risk factors, and really identifying the optimal outcome. I feel like it is our role to educate patients and really focus in a shared decision-making model in choosing any of the treatments that we are going to consider together. And then lastly, really treating obesity as a chronic disease in order to optimize any outcomes. And with that, I will end, and I will look forward to taking any questions. Thank you.